I am Dr. Bharat Koyani, MD pathologist residing in Rajkot, Gujarat, India. Today we will discuss a clinical case. A patient, 42 years old male, came to the consultant and he complained in typical Kathiawadi Gujarati language that સાહેબ જેવી મેં પાણીની ડોલ ઉપાડી કે કડમાં કડાકો બોલી ગયો, બહુ દુખે છે. મીન્સ as soon as I lifted a water filled bucket, there was a cracking sound in my back. It is very painful. Consultant took X-ray in his own hospital. He examined the X-ray and said to the patient that in L4 and L5 vertebrae, there are minor fractures. He prescribed analgesic and other medicines. After 15 days, patient came again without any relief in follow-up. Then he was referred to another consultant. He examined the previous X-ray and did the same thing. After 15 days, there was no relief in the pain. Patient was disappointed. Some layman told him that your hemoglobin level may be low and pain may be due to that low hemoglobin level. He went to the laboratory and hemoglobin level was 8 gram%. Somebody told that you go to this physician, he will raise your hemoglobin. He consulted physician. Physician requested investigations, hemoglobin level and peripheral smear examination to a pathologist. In a laboratory, the hemoglobin level was 8 gram%. When the pathologist examined the peripheral smear, surprisingly, he saw Rolex formation of RBCs, and after scrupulous search, he noticed the plasma cells in a peripheral smear. On scrupulous screening of the peripheral smear, almost more than 5% of the differential count, there was plasma cells. He did electrophoresis, zonal electrophoresis in his own lab, and there was a conspicuous M band was seen in gamma globulin region, which was darker than albumin in the electrophoresis pattern. He suspected multiple myeloma in that patient. The patient was sent to cancer hospital where he was further examined. Bone marrow and other investigations were done, and multiple myeloma was confirmed in a 42 years old male patient. Now, what is the lesson of this case? Whenever the patient presents with back pain or pain in any type of bone, after the age of 50, the orthopedic surgeon should be cautious about the multiple myeloma condition. The presentation of multiple myeloma is of various types. Sometimes it may present with recurrent bacterial infection, as for example, pneumonia or urinary tract infection. Now, recurrent bacterial infection means more than 2 times of infection in a year. It should alert to the physician, urologist, and when bone lesions or bone pains are there, it should alert orthopedic surgeon. Now, what should be the approach in this type of cases? Now, firstly, in a routine examination or investigations, we should ask for CBC with peripheral blood smear. Serum calcium should be done, serum protein should be done, and most importantly, routinely, we should ask for ESR. Nowadays, ESR is almost completely discarded test, but we have some reasons. Whenever there is a rapid rise of ESR, means when there is a fall of RBCs in a ESR tube, very rapidly, within 15 minutes, you can get more than sometimes 150 millimeter of ESR within 15 minutes. In this condition, we should go for serum protein electrophoresis. The retired head and professor of pathology, Dr. Nilesh Shah, always tells that whenever ESR is raised, you go for zonal serum protein electrophoresis routinely. And he detected many cases of multiple myeloma by this technique. Again, in peripheral smear, a pathologist how he should examine peripheral smear. Firstly, he should examine for Rolex formation in each and every peripheral smear. Whenever there is more Rolex formation than usual, he should search for plasma cells. Now, scrupulous screening of peripheral smear is needed. Sometimes, when the number of plasma cells are less, then it may fail to detect plasma cells in peripheral smear. Thirdly, he should also examine the background staining. Sometimes background staining due to high protein level in the serum may indicate this type of raised protein. Now in this case, when the fracture in L4 and L5, it was a pathological fracture. No history of trauma was there. The consultant should have taken the other X-rays, as for example, skull or thorax region. He might have detected punched out borders in the radiolucent areas in the skull. Now sometimes when the patient presents with recurrent infection, it may go to the urologist or physician. So urologist, orthopedic, physician and pathologist all should be aware of the multiple myeloma case presentation. Now, what the message of this presentation? I would like to tell you that 1% of every malignancy, 1% of the total malignancies are that of multiple myeloma. And about 13% of the hematological malignancy is multiple myeloma. So today's message is that the multiple myeloma in clinical practice is not an uncommon condition. Rather, I would like to tell you that multiple myeloma is a common condition. We should always think when the presentation is that of bony pain, recurrent infection, or whenever there is a proteinuria, and very well given is the diagnostic criteria by the International Myeloma Commission. So think of multiple myeloma in your clinical practice. Keep in your mind and improve the knowledge about the multiple myeloma. Thank you very much.